Hi, my name is Sasha Birge. I'm a physiotherapist and athletic trainer. In this practical session, we're going to discuss how you can optimize your criterion-based shoulder rehabilitation using objective measurement technology. As with many body regions, but the shoulder in particular, we're starting to move towards an impairment-based treatment model. Now, it's important to consider our healing-based timeframes. We do want to focus on how we can quantify physical impairments so we can use that information to help guide our intervention. That's what we're going to focus on mostly in today's practical. In this prac, we're going to be reviewing a variety of different objective measurement techniques that you can use to evaluate and track the physical impairments throughout the course of a shoulder rehabilitation. For this prac session, we're going to use Cal as our patient. Now, Cal sustained a right-sided shoulder injury. The first thing we're going to do is look at range of motion. Now, from a practitioner standpoint, it's fairly easy to eyeball range of motion, especially at the glenohumeral joint. But one of the reasons that we want to measure it objectively is because we want to give that feedback to our patient. For two reasons. One, if a patient's had surgery, they might have a postoperative protocol that dictates that they can only move their shoulder a certain amount of degrees. Instead of getting a goniometer out to show them, it's easy to use an inclinometer. We're going to use the Vault Dynamo for this purpose. The next thing we want to do is we want to train proprioception. So one of the things that's commonly injured after an injury, surgery, or both is a patient's proprioception, especially at the shoulder. And we can use the inclinometer to help train their proprioception. I'll show you how we do that. So if there's an example where you have a patient who has a postoperative protocol that limits their external rotation, you can use the inclinometer to give a patient feedback of exactly how much motion they should be able to exhibit. So in this case, I'm going to give Cal feedback using the inclinometer. So Cal, you're only allowed to externally rotate to 30 degrees for the next few weeks. So let's see what that looks like. So when I click start, hold nice and steady. When it says go ahead and move until this says 30 degrees. Perfect. You went a little bit over. Go ahead and go back. That's what the feedback is for. It's hard for you as a patient to understand what 30 degrees feels like, so that's why we use this. Let's try that one more time. And when you're ready, just nice and slow to 30 degrees. Perfect. And go back. Next thing we're going to do is we're going to look at quantifying proprioception. So proprioception, as we all know, is our ability to sense our body's position in space. Now that can be impaired after an injury or after surgery. So what we're going to do is use a similar mechanism. I'm going to give Cal a number to externally rotate to while he watches the feedback of the dial. Then I'm going to have him close his eyes and try and replicate the same thing. So Cal, this time what I want you to do is I want you to go to 25 degrees, all right? Watch the dial so you know that you're at 25. Then we're going to come back, we're going to do the same thing with your eyes closed and see if you can achieve the same number, all right? Hold nice and still. And let's go to 25. Perfect. Now you can see what 25 feels like. Come on back. This time close your eyes, and I want to see how close to 25 you can get. Hold nice and steady. And when you're ready, try and go to 25 again. Tell me when you think you're there.
Yeah.
Cool. Awesome. So undershot it by about 4 degrees. But this shows me how I can quantify your proprioception. So proprioception is often something that we see impaired after injuries and surgeries, but it's not something that we typically do well at assessing. So using something like an inclinometer can allow you to measure active and passive joint position sense by giving the patient a target to move to and then reassessing to see how well they can replicate that position. As with range of motion, there also might be restrictions on strength after surgery. However, it's often difficult for a patient to actually know what it is or what it feels like to apply 5 kilos or 10 kilos worth of force after they've had surgery. So rather than them picking up a weight, especially in something like external rotation, what we can do is use the dynamometer to give them an idea of how much force they're applying. So what I'm going to do is I'm going to give Cal a bit of feedback on how much force he's applying, and I'm just going to use my hand to block. So I'm going to pop the dial down here and let Cal watch. But because, let's say, Cal's been given a 5 kilo restriction in external rotation, what I can do is I can use the dynamometer to give him feedback of what that feels like. So I'm going to place my hand here, and what I'm going to do is I'm going to say, Cal, I just want you to push in until the dial hits 50 newtons, which is roughly 5 kilos. So nice and gentle, go ahead and push into me. Push, 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 and relax. Perfect. So in different circumstances, the load restriction may be different. It doesn't have to be 5 kilos, could be 3, could be more, could be less. But the idea is that a patient may not understand what it feels like to produce that amount of force that they've been prescribed. So using a dynamometer, we can give them an idea of how much force they're applying. Similar to giving a patient feedback on their range of motion and training proprioception, the dynamo is a really good device to help give that patient feedback. And then we can progress this into some of their isometric training rather than just having them push into a fixed object. Using the dynamometer gives them an understanding of how much force they're applying. So we just spoke about how we can strap the dynamo onto the patient's hand to give them early feedback of how much force they're applying after injury, after surgery, when we're in the early stages of rehab. But we want to consider a few things as we start to progress our strength testing. So we're going to discuss a few different ways to do handheld dynamometry as well as fixed frame dynamometry when our patient's starting to get stronger. So here's the first consideration. We'll obviously want to progress our testing in range of motion from neutral out into greater positions of abduction and flexion. But we also want to consider how we perform our tests. So we're going to discuss the differences between a make and a break test. For those of you who aren't familiar, it's important to go over it. Everyone's learned different techniques, and sometimes we don't appreciate how these two might be different. First, we're going to discuss a make test, and that's using a handheld dynamometer. So Cal, go ahead and tuck the towel in. The reason we tuck the towel in is because we want to fix the humerus to the patient's body. Often the compensation we see as someone tries to externally rotate is that their elbow will flare out, and that gives a contribution from the deltoid in abduction. And what we want to do is we want to measure as best we can the intent to purely externally rotate. So a make test, as I learned it, is for a patient to make as much force as they can into a fixed object. So my cue to Cal here, now it's important that I brace well. We can also do this against a fixed object, but this is the way that I would do it. I'd say, Cal, what I want you to do, when I say go, push into me as hard as you can. 3, 2, 1, go, push, 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 push. Awesome. And if I'm happy that I'm really stable and Cal's applying good force and we're seeing little movement, then I'm getting a good test. If we start to see a lot of movement, then that drops the validity of the test because, again, an isometric test means no movement. If we get movement, I might want to set the test up differently or have Cal strap this back on, push into a fixed surface. Next thing we're going to consider is a break test. The way I learned this was to break the patient's force. Now you have to be careful with who you do this with and how far along in rehab because this can be a bit more provocative. Essentially what I'm trying to do is I'm trying to overcome Cal's force, and my instructions to Cal will be, Cal, what I want you to do is hold here and don't let me move you, okay? I'll apply the dynamometer to the body region and I'll say 3, 2, 1, go, and I'm going to try and push until Cal can no longer apply force at the point at which he breaks. So what I'm trying to determine is the maximal amount of force that Cal can apply before the external force overcomes his ability to stabilize that joint segment. As we saw in the last video where I was assessing Cal in a standing position, what you can see is that there's a lot of additional movement, especially when I perform the break test. What I want to do is ensure that I'm just measuring force of Cal's external rotators as best we can. So we want to avoid additional movement. Here's a way that I like to do that test in a different position where I feel like I've got more control over the movement and we can really isolate shoulder internal or external rotation. In this case, we're going to do internal rotation. So I'll have Cal prone on the plinth. I'm going to go ahead and support his arm so he's at 90 degrees abduction. His humerus is in line with the plane of his torso. And then from here, I'm going to have him internally rotate. So I'm blocking in this position, nice supported arm, handheld dynamometer in contact with the patient's body. And when I say go, it's going to be a make test. Cal's going to push as much force as he possibly can. 3, 2, 1, go, push, 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 and relax. Good. I feel like I've got good control in this position. We've really isolated the internal rotators. Now, again, in the last video, we looked at testing in neutral. Harder to test in neutral in this position, but I feel like once we progress to 90 degrees, we've got a good amount of control, and then I can flip around and do the same thing for external rotation. As a patient progresses with their strength, and it's no longer easy or feasible to perform strength testing using a handheld dynamometer, simply because the patient gets too strong and it's hard to stabilize them using the technique that we showed earlier, we might progress to testing with a fixed frame dynamometer, in this case the force frame. So what we'll do is we'll test Cal's strength in internal and external rotation at 90 degrees of abduction. The same principles apply. This is a make test because Cal's pushing into the pad as hard as he can. But unlike the previous test where I was in control and could make sure that Cal was not moving and I could stabilize him as much as possible to really isolate that movement, there's different ways of doing that here. So when we go to perform the test, there's a couple things we have to consider. First is how are we going to provide a cue that elicits the response from the patient that we want. Early on, what I want to look at is strength. Now we can also look at things like rate of force development, but before we look at rate of force development, I'm just going to isolate strength here and my cue should correspond accordingly. So what we'll do is we'll measure external and internal rotation here. Now the other thing I want to make sure of is that Cal's in a nice stable position. In this position, I'm going to keep my feet on either side of the shoulder well to make sure we get as little aberrant movement as possible. And because we're just cueing for strength, I'm going to tell Cal to push as hard as he can, not worry about speed. I'm going to count him down and then he can relax. So Cal, go ahead and place your hand in contact with the upper pad for external rotation. I'm going to say 3, 2, 1, go. When I say go, you build up force pushing as hard as you can and then you'll relax on my cue. All right? And 3, 2, 1, go. Push, 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 and relax. Good. Nice. You develop force pretty quickly. If you'd like, You can build it up gradually over time, all right? Now, gently place your hand in contact with the pad below you for internal rotation here. And 3, 2, 1, go. Push, 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 and relax. Excellent. Now, if we have a look at the curve, you can see on that first external rotation rep, quite a steep spike. So Cal was applying a lot of force, but also trying to develop that force quickly. In the second one, you start to see a little bit more of a gradual line. He's building up force, but he's doing a little bit more slowly. There's nothing right or wrong about those tests. It just shows how my cueing really influences the way my patient applies force. Now, in addition to restoring range of motion and strength, the other thing we want to restore and improve is a patient's ability to tolerate and weight bear through their upper body. So a nice easy way to do that is quantifying that using force plates. So what I'll do is I'll set them up just using the force trace for any test, and we can progress from kneeling into a normal push-up position. So Cal, when you're ready, go ahead and place your hands down in a kneeling position. And what I want to do is, in addition to quantifying it for my own purposes, is give the patient feedback of how much force they're producing through either side in this static position. Now, just like proprioception being impaired, a patient's ability to determine what is and isn't symmetrical in their upper body weight bearing may also be impaired following injury or surgery. So what I'll do is I'll just pop the trace in front so Cal can see it, and I'll give him a gentle cue or a little bit of a constraint saying, you know, Cal, what I want you to do, gently shift side to side. I want you to push over to the right side, maybe until you feel 3 out of 10 pain, or go ahead, once we progress a little bit further, try and put as much weight on that right side as possible. So the patient can get an understanding of how much weight they can shift side to side, and it's good to progress. Again, once we're happy in the kneeling position, go ahead and into a full push-up position, Cal. Good. Same thing there, go ahead and shift side to side. I might say, Cal, I want you to shift as far as you can onto the right, hold for 5 seconds, back onto the left. You can determine based on the patient you're working with and what your rehab goals are, how you want to progress in an exercise like this. So when we become comfortable with the patient's ability to bear weight through their upper limbs, we then want to start to introduce things like a pressing pattern so we can implement push-ups and we can quantify the different characteristics of the push-up using the force decks. So what we'll do is we'll look at a few push-ups, and I just want to see what Cal would normally do. So Cal, when you're ready, now what we can do is we can start in a kneeling position, but for the purposes of this prac, we're just going to go straight into a normal push-up. So I don't want to be too strict with my cues. I just want to see what Cal's normal patterns are. If I provide too many constraints, he might do things differently to what his normal tendencies are. So in a nice stable position, make sure that the trace is staying still. And Cal, when you're ready, go ahead and perform a push-up. Cool. Hold for a second. We see the rep is detected. And one more time, and go for it. Perfect, and relax. So we can see the data here. What we're looking at is, as expected with a right-sided injury, Cal's placing a little bit more force through his left side. And we can see that in both the eccentric and the concentric phases. So the metrics I've chose to look at is the eccentric mean force asymmetry. So on the way down, on average, which side is producing more force? And then we're looking at the same thing respectively for the concentric phase. This can give us an idea of what we want to focus on as we start to implement our exercise intervention. Now, in addition to assessing the push-up, we can also look at maximal strength doing an isometric push-up using the force decks. So what I'll have Cal do is do a push-up into this bar. So Cal, when you're ready, go ahead and hop into position. Feet out into push-up, good. Just be careful there. Now gently take up a little bit of pre-tension. Hard to hold this position, so we'll go quick. When I say go, Cal, you want you to push hard and as fast as you can. 3, 2, 1, go. Push, 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 and relax. Nice. Perfect, and it picks up our rep there. Hard to do multiple, so I'll just do one for now. But what we're looking at is peak vertical force asymmetry. So when Cal starts to apply force, which arm is producing more force? We also look at start time to 80% neck peak vertical force. That sounds like a very sophisticated metric, but what we're really looking at there is of Cal's overall peak force, how long does it take him to get to 80% of that? So what we're really looking at is how long does it take him to produce the bulk of his maximal force potential? And the last thing we'll look at is RFD at around 150 milliseconds. And again, this depends on the cue. Just like all our other isometric testing, we can cue for peak force, rate of force development, or a combination of the two. So once we've looked at the push-up pattern, we're okay with the quality of the movement. We've looked at a iso push-up with max strength. Next thing we want to look at is max power, so we can implement a plyometric push-up. So Cal, when you're ready, go ahead and hop into push-up position. Now you can vary your cues with this. Usually what I tell my patient is I want you to do a push-up as hard and as fast as you can, fly into the air as high as you can, and land nice and steady. All right? Cal, when you're ready, go for it. Good. and relax. We'll just do 1 rep for the purposes of today. And what I'm looking at here, similar to my push-up, I look at the eccentric and concentric mean force asymmetries. So as he's loading in the eccentric phase, as he's expressing force in the concentric phase, I want to see which one is doing more work. And then the output, which is the height of that push-up jump or plyo push-up, I want to measure that as well. A concept that people are familiar with for the lower body is the eccentric utilization ratio, or EUR, which looks at a patient's ability to produce concentric force without the stretch shortening cycle preceding it, and then with. That's using the squat jump and the counter movement jump. We can actually do a similar thing for the upper body using those same 2 tests respectively, and just identifying that they were done in push-up position. So Cal, what I want you to do is when you're ready, hop into push-up position. We'll do a non-counter movement plyo push-up first. So my cue with this, Cal, is what I want you to do is I want you to go down into the position where you're going to begin your push-up. Go ahead, go down, hold 3, 2, 1, explode off. Perfect. And that should pick up a squat jump. Awesome. Now we'll do it as a counter movement jump. Same thing we did in the plyo. Cal, when you're ready, do a plyo push-up, explode as high as you can. 3, 2, 1, go. Perfect. Nice. Awesome. And what we can do is compare the height for both of those to determine our upper body EUR. So we spoke earlier about implementing the ASH test early on, using a handheld dynamometer like the Dynamo and strapping it to the patient's wrist so we can get through that test quickly and easily. And the purposes of doing that is just to look at our peak force values when we're just starting to build strength in our rehab, but not yet looking at rate of force development. But when we start to improve our intent and RFD, we want to then progress our testing to the force plates. And so just for the purposes of this prac, we'll just do an eye test. But what Ben Ashworth encourages people to do is not just look at peak force and not just look at RFD, but look at both of them and then compare the two. So what we'll do is we'll do 2 different tests and I'll show you how we cue differently. So Cal, go ahead and get into position. First, we're going to look at peak force. So my cue to Cal for this is to generate force at a moderate pace, but to just build up to his peak force overall, expressing as much force as possible, but not with the intent to do it as quickly as possible. So when you're ready, Cal, 3, 2, 1, go. Build, 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 push, 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 and relax. Nice. So we can see the test is captured there. We're happy that the slope is nice and slow and controlled. He's taking his time to build up force in that rep, but he's not doing it too quickly. So that's a good rep for peak force. Then what we want to do is look at peak RFD. So he doesn't need to hit the same strength value, but I want to see how quickly he can apply force when I provide him the cue to do so. So Cal, with this one, I just want you to apply force as quickly, as fast, as hard as possible in a nice quick burst. Hold, 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 and then relax. All right? 3, 2, 1, go. Push, 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 and relax. Awesome. And go ahead and relax your arm. We can see the differences in those reps, and what we're looking at in the first rep is just the peak vertical force. We want to see simply how much force he applies. But then what we look at is when we're comparing the two is look at our RFD metrics, roughly at about 100 milliseconds. And then we also want to see how much force he produces at time by looking at this absolute impulse at that same time point. So if I want to perform the ASH test using the Dynamo, it's actually a little bit quicker and easier to perform than it is using ForceDex because I don't have to rearrange the patient or the force plates. I can just simply move their arm into a different position, and I can use the test battery features, which allows me to run through the tests really, really quickly in succession. So I'll just bring up Cal's profile, and what we'll do is we'll just run it through one side. Now, like all the other tests we've performed, anything that we normally do for the uninvolved side, we'll perform for the involved side, but just for the purposes of this prac, we'll stick to one side. So we'll start on the right side, get Cal into position, so arms straight up overhead, 180 degrees, making sure that the other hand, if you can't see it, is down at his side for the eye position. Now, there's a certain amount of force being applied. I don't zero it because this is some of the force that Cal's already applying into the Dynamo, and I don't want to lose that in my measurement. Now, when I say go, again, looking just at peak force, not rate of force development. Cal, I want you to build up force, applying as much force into the ground as you can. 3, 2, 1, go. Push, 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 and relax. Lift your hand up so we measure the rep. Good. And perfect, relax back down. Now we can do that multiple times depending on how many reps we want to collect. I will delete any aberrant reps. Let's go on to the next test. Cal, go into the Y position when you're ready. I typically eyeball it, but we can use a goniometer if we want to be sure that Cal is in the appropriate Y position. Same thing, hand is behind his back on the other side now. And 3, 2, 1, go. Push, 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 and relax. Go ahead and lift the arm up. Perfect. We'll move on to the next test. Come on down into the T position and rest. Perfect. And 3, 2, 1, go. Push, 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 and relax. Excellent. And we've got all our data there. If we just did it on the one side, we can compare longitudinally to any previous tests and also compare it to the other side. Now that's a really quick and easy way to get through the ASH test if I'm just looking at strength in the earlier phases of rehab before I'm interested in some of my RFD metrics using the dynamo. We'll progress to doing it later on the force decks. So we spoke earlier about giving the patient feedback about their force expression by using a dynamo, placing it on their wrist, and having them push into a fixed surface and giving them feedback of how much force they're producing. But when we want to progress our isometrics, we'll start to get into some of our gym equipment. So I'm a big fan of just using your standard isometric walkout with a band. You get the limb and the joint in the position that you want, and then gradually increase your resistance by moving out. So Cal, let's set you up in that position again. Arm at 90 degrees. I'm gonna put this around his hand, elbow at the side. You can fix it with a towel if you'd like, but just from here, what I'm gonna tell Cal to do is gently start to shift his position out as far as he can until he feels like he's about to let that position go. Hold, again, 10, 20, 30 seconds, whatever's appropriate for your specific protocol, and then relax off. So Cal, holding that position, go ahead and pop out. Good. If that is the place where he feels like he can hold a resistance, but he's about to give up, we'll hold there for a certain prescribed amount of time. And then to relax, he can go into external rotation or he can just walk back in. So go ahead and walk back in there. Easy one to do. Remember, from a physics perspective, thinking about torque, if we want maximal tension on the joint that we're training, we want to make sure is that the angle of pull of the band or the cable, whichever one you're using, is perpendicular to the limb segment. So I'll take this for a second, Cal. So bear in mind that if you want to work in that neutral range, you've got to make sure that you're in neutral and that the band is perpendicular to the forearm. If you were to change position, so if I were to move around like this and then walk out, notice that the line of pull is nearly in line with my forearm. So even though the tension may increase uniformly on the band, we're not getting the same amount of tension increasing at the joint. So as far as the walkouts go for isometrics, it's a really nice way to progress. We can do it in internal rotation, the way Cal's set up here, flip him around, do it in external rotation. We could even progress to a 90-90 position, so he does the same thing, but a bit more abducted. So walking out for internal rotation where the band's pulling him back. Let's get into that position, Cal. So turn facing that way, just like this, walk out that way. He could swing around and do the same thing in external rotation. Come on back in. For those same tests that we did for the ASH test position, so we got your T, your Y, and your I, we could do the same thing here. So Cal, go ahead and face that way. Again, a bit more torque placed on the shoulder, so got to be a bit careful here, but gently start to walk out forward a little bit. I could do the same thing here, build out some strength in that T position, come on back, progress to the Y and the I respectively. So it's a really nice way to do it. Again, hard to quantify, but it's an easy way for a patient to build up and it's fairly self-limiting. One thing to be mindful of is when we're doing our isometrics is what position the joint is in and then what length the muscle's in. So are we working into inner range or outer range, or are we in neutral? So the exercise we just showed with Cal before, he was in a relatively neutral position. So forearm was perpendicular to his body. Now remember, the way to get maximal force is by keeping the forearm perpendicular to the band. So if we wanted to work into an inner range position, rather than me going into inner range, where now the line of pull with the band is no longer perpendicular to my forearm, but rather almost in line with it, even though when I go out, I'm applying a lot of tension, I'm not actually applying a lot of force at the shoulder. So if I want to work into a different range, rather than changing the position of my arm, what I can do is change the position of my body. So if I want to work the internal rotators in an outer range position, I can just turn out a little bit and then walk forward. So I'm doing the same thing, but I'm just applying the same amount of force in an outer range. And then from an inner range perspective, again, instead of going into internal rotation and walking out, I can turn my body a bit, making sure that my forearm is still perpendicular to the band, so that I've got to apply the maximum amount of torque, and then going out this way. And then you can progress to your isotonics with a band, with a cable, with a weight. Just remember from a torque perspective where you're going to be able to express the most amount of force. And when it comes to your programming, just keep that in mind for what implement you choose to progress to your isotonic exercises. So in addition to progressing our isometrics, working into our isotonics, both through eccentric and concentric phases, one of the things I like to do is overload the eccentric phase from a force standpoint, but also the rate of force development requirements for the same exercise. Easy way to do that is, Cal, go ahead and get in that same position you would do a walkout. And then what I want to do is, Cal, go ahead and walk out a tiny, tiny bit. Now from here, I want to work on Cal's rate of force development eccentrically. So an easy way to do that is I can take up the slack from here. Notice it's all gone. Now what I'm going to say to Cal is I want to keep that nice and steady. I don't want, when I let this go, for your arm to fly out. I want you to be able to apply force quickly. And I might count them down so it's predictable the first time. 3, 2, 1, go. Perfect. So see how he has to react quickly. We can progress that, we can go out, we can go in depending on what he can tolerate. We can also work on neuromuscular control by making it an unpredictable exercise. So Cal, let's do the same thing. Go ahead and go back out. This time, Cal, what I want you to do is close your eyes. I'm not going to count down. He's got no idea when I'll let go. So it's a nice, easy way to progress this from a load standpoint, from a rate of force development standpoint, and working on his neuromuscular control. Just like some of the other isometrics that we did, we can do it for internal rotation, external rotation, neutral, go up to 90 degrees for both, and we can even do it for some of those IYT positions as well. So when we want to move on to progressing our load-bearing progressions through the upper limb, easiest way to do it is obviously work from upright against a wall into a bit more inclination, then working into a flat position from the knees and then into a normal push-up position. But a nice easy way to do it is if you have a rack and you have a cable, is to provide the patient with a little bit of assistance when they're going through all those movements. So same thing that we did from our testing progressions, we'll do a similar exercise progression using a bit of assistance. So Cal, go ahead and pop that around your shoulders and go into a kneeling position when you're ready. So when it comes to just weight bearing, an easy way to do that is I'll let Cal kind of walk your hands out forward, keeping your knees on the ground. And then from here, go ahead and shift side to side, giving him a little bit of comfort, having him feel how much resistance there is. Now, at your own discretion, determine what kind of band you want to use. Make sure there's enough resistance, but not too much. Cal, when you're ready, go ahead and lift the knees up into a normal push-up position. We can shift side to side, accepting more load through that injured upper limb. And then when we're ready, we'll go into a push-up progression. So just do a normal push-up when you're ready, Cal. Perfect. And we can change the tempo if we like. We can work on a little bit of speed. Hop back onto your knees for a second. And then what we'll do is once we've got the push-up down, happy with a little bit of load and control through there, what we can do is we can do our landing progression. So tolerating the weight acceptance through the upper limb. So Cal, in this position, when you're ready, go ahead and fall forward and catch yourself nice and controlled. Perfect. And when he's ready, what we can do is do the catch, push himself back up. So a modified plyo push-up. So when you're ready, Cal, let's do the same thing. So leaning forward, catch, and then push back up. Awesome. And then when we're ready, ultimately we can go into a plyo push-up with the assistance of the band. So hop on down. Good. So let's do that non-counter movement plyo push-up. So I want you to go down and hold for a second. So down to the bottom, 3, 2, 1, push. Perfect. So we've got that concentric bias. Then we can do the normal counter movement plyo push-up. When you're ready, Cal, whole thing when you're ready, go for it. Perfect. And hop back up onto the knees. So that's a pretty easy way to introduce upper body weight acceptance, landing, and then a push progression. Thanks to everyone who watched this prac. I hope that this provided a little bit of insight into other ways that you can use objective measurement technology to help enhance the decision making when it comes to shoulder rehabilitation. By no means is this an exhaustive list of everything you can do when it comes to objective measurement around the shoulder, but the idea is to give you a different perspective on what you can do, hopefully give you some things that you can add into your practice. If you want to discuss this or have any questions about what we did in this practical, feel free to reach out to me via the contact information below.